Section 3. Reducing addictive behaviour. The theory of planned behaviour as a model for addiction prevention, Asgen 1989. Theory of planned behaviour is a model which helps understand how to intervene to prevent addictive behaviour. Main assumptions. According to this theory, an individual's decision to engage in behaviour, in this case give up an addictive behaviour, can be directly predicted by their intention to engage in that behaviour. Intention is a function of 3 factors. 1. Attitude to the behaviour. This arises from the individual's personal views, that is, their attitude towards the behaviour in question, how desirable it is to, for example, give up alcohol. 2. Subjective norms. They involve the individual's subjective awareness of social norms relating it to the particular behaviour. They involve both a person's beliefs about what they think significant others feel is the right thing to do, as well as the perceptions of what significant other people are actually doing. 3. Perceived behavioural control. Whether a person believes they can carry out the behaviour that will influence both their intention to behave in a particular way and whether they will perform the actual behaviour. A. The more control people believe themselves to have over the behaviour in question, they will have a stronger intention to actually perform that behaviour. B. An individual who has higher perceived behavioural control is likely to try harder at their behaviour and persevere longer than someone who has low behavioural control. This is similar to Bandura's concept of self-efficacy, the belief that one has the skills and resources necessary to achieve one's goals and overcome any external barriers. It involves the belief that you can actually carry out a particular behaviour. The theory of planned behaviour can be used as a way of targeting interventions. Interventions may aim to change 1. Individual attitudes, information given about the risks of addiction, for example graphic images on cigarette packets, educational programmes about the risk of smoking. 2. Social norms, changing norms about smoking, for example government ban on smoking in the workplace. 3. Perceived behavioural control, educational programs aimed at children showing them how to refuse cigarettes or drugs, CBT. 4. Intentions not to carry out the behaviour. Graphic images on cigarette packets and educational programs about addiction prevention. Evaluation of the theory of planned behaviour. Strengths. Very influential and much used model. Currently the most popular cognition model used in health psychology. Meta-analyses have shown that TPB can account for about 60% of the variability in people's behavioural intentions, with self-efficacy seeming like the key component. Accurately predicts behaviour and can help with some addictions, including cigarette smoking, alcohol and drug use, and gambling behaviour. For example, in a study of smoking behaviour, Godin et al. 1992, collected data about smoking behaviour using interviews and self-report questionnaires. They followed up the participants 6 months later and found that the most important predictor of whether people continue smoking was low perceived behavioural control over their smoking. Intervention programs should therefore work with smokers to increase the extent to which they feel they have control over their smoking. Limitations. Too rational. The TPB fails to take into account emotions, compulsions, or other irrational determinants of behaviour. When people fill out questionnaire, they may find it impossible to anticipate the strong desires and emotions that compel their behaviour in real life. The presence of strong emotions may help explain why people sometimes act irrationally by failing to carry out their intended behaviour, for example, stop drinking, even when they have stated that they intend to stop and when it is in their best interest to do so. Intention, behaviour gap. Armitage and Connor, 2001, conducted a meta-analysis of studies using TPB, found that the model was successful in predicting intention to change rather than actual behaviour change. This was particularly the case in the prediction of health behaviours that involved the adoption of difficult behavioural change, for example stopping taking drugs, eating a healthy diet. Types of intervention and their effectiveness. Biological interventions. Agonist substitution, for example nicotine replacement therapy. This provides the addict with a safer drug that is chemically similar to the addictive drug. Nicotine replacement therapy works by both reducing withdrawal symptoms by providing nicotine, but may also desensitize nicotine receptors in the brain so that if a person smokes a cigarette while on nicotine replacement therapy, the cigarette will seem less satisfying. Agonist substitution. for example nicotine replacement therapy. This provides the addict with a safer drug that is chemically similar to the addictive drug. Nicotine replacement therapy works by both reducing withdrawal symptoms by providing nicotine, but may also desensitize nicotine receptors in the brain so that if the person smokes a cigarette while on nicotine replacement therapy, the cigarette will seem less satisfying. Nicotine replacement therapy includes gum, patches or inhalers, which deliver nicotine in controlled doses via the skin into the bloodstream and then into the brain. Use. Nicotine patches are available in different strengths and use varies according to how many cigarettes a person smokes each day. 25 milligrams for a person who smokes more than 10 cigarettes a day, and 15 milligrams for the person who smokes less than 10. It is recommended that the full-strength patches are used for 8 weeks, and if the smoker has successfully abstained, they then reduce the dose for a further 4 weeks until they are smoke-free. Effectiveness. Silogy et al. 2002 found in a recent meta-analysis that nicotine replacement therapy is effective. People who use it are approximately twice as likely to quit smoking for at least 6 months compared to a control condition, usually with a placebo patch. However, studies of nicotine replacement therapy show that although they are more effective than placebos initially, more than 70% of users return to smoking when treatment stops, and at a 9-month follow-up, the difference between the placebo patch and the nicotine replacement therapy group had disappeared. One advantage of nicotine replacement therapy is that it is readily available in UK pharmacies and on prescription from the doctor. However, it is expensive. Addicts do not find low nicotine doses satisfying, and that can lead to them giving up the therapy. There is also controversy over whether the nicotine in nicotine replacement therapy is still harmful despite this. A cost-benefit analysis would suggest that nicotine replacement therapy is a better option than smoking cigarettes. Antagonist treatments, for example bupropion, known as Zyban. Bupropion is a drug that increases levels of dopamine in the brain, which reduces cravings and withdrawal symptoms, and blocks the nicotine receptors in the brain, reducing the pleasurable effects of smoking. The smoker starts taking twice daily doses of 150 milligrams of bupropion for 1 to 2 weeks. This builds up bupropion levels. They then quit smoking completely. They continue to take bupropion for about 8 weeks to help them get through the withdrawal cravings. It is only available on prescription and is not available if the person is then pregnant or has some pre-existing conditions, for example liver or kidney problems or a history of seizures. Effectiveness. Jorenby 2002 found that sustained release bupropion 150 milligrams taken twice daily has been found to be either equivalent or slightly more effective than nicotine replacement therapy that is just over twice as effective as a control condition. Bupropion is generally well tolerated with few side effects. However, bupropion has a slightly increased risk of seizures, making it inappropriate for those vulnerable to seizures. It is only available on prescription. This lack of availability makes it less likely that people will continue with the treatment. Despite the findings that nicotine replacement therapy and drugs like bupropion double the odds of successfully quitting in the short term, rates of smoking cessation using current methods are still low, with over 70% returning to smoking at 6 or 12-month follow-up. Evaluation for biological treatments. When biological therapies are used in combination with psychological therapies, smoking cessation rates at 6 and 12 months are enhanced. Ethical issues. Using medical interventions takes responsibility away from the addict for their recovery. They may be less motivated to continue with the treatment. Isolating the effectiveness of biological interventions can be difficult because there may be several influences on a person's ability to quit smoking, for example, smoking ban, TV adverts. Psychological interventions. Cognitive behavioral therapy. Cognitive behavioral therapy has two important components: analysis of faulty thoughts and beliefs associated with the addiction and skills training. Analysis of irrational thoughts. The client and therapist identify the client's thoughts and feelings before and during carrying out the addictive behavior. This allows the client and therapist to identify high-risk situations that may lead to relapse. Also provides insight into some of the reasons why the individual may be indulging in addictive behaviors, for example, to cope with stressful life situations or to provide risks/thrills which may not otherwise be available in the patient's life. Skills training. Helps the addict addict unlearn habits associated with their addiction and learn healthier skills and habits. Initial focus is on skills related to control of their addiction, for example, identification of high-risk situations, being able to refuse the drug when it is offered, and coping with cravings. The focus is on identifying and reducing habits associated with drug-using lifestyle by substituting more enduring, positive activities and rewards. Skills training also focuses on techniques to recognize and cope with urges to do with their addiction. It can also be used to help patients learn to tolerate other strong emotions such as depression and anger. The client practices the skills in the therapy session and then reports back to the therapist on how successful they were when used in real-life setting. CBT is usually seen as a short-term therapy. Patients may be offered 12 weekly sessions of CBT. Effectiveness. Ledecoeur et al. 2001 randomly allocated 66 gamblers to either A, CBT group where their irrational thoughts about gambling were questioned and they were given training in relapse prevention, or B, control group, placed on a waiting list for treatment. 86% of those who completed the CBT were no longer seen as pathological gamblers, as defined by the DSM-IV. Patients who had CBT had higher self-efficacy and were coping better at a 1-year follow-up. Other studies have been less favourable. Morgenstern et al. 2001 compared CBT with the Alcoholics Anonymous 12-step approach and found little difference in effectiveness. Evaluation. Helps the client to deal with other issues in their life, which may help with the factors that make a person vulnerable to addictive behaviour. Difficult to evaluate effectiveness. CBT is often used at the same time as other treatments, for example drugs, self-help groups, so it's difficult to assess which component has been beneficial. The definition of successful treatment varies between people. Abstinence might be a clearer and more easily measurable outcome, but gaining control over substances and improving your lifestyle can also be beneficial.